Becky. So welcome everyone, and a warm welcome to those attending and also to our viewers watching live on the Council's YouTube channel, Hillingdon, London. Details of the business to be considered today is shown on the agenda, copies of which are available in the room, and it's also accessible online under the live broadcast. For those present in the room and intending to speak, please note that you will be filmed and any statements you make will be recorded and made public. For those solely observing in the room today, you may wish to know that the camera is angled away from the public gallery where you are sitting. At the end of the public part of the meeting, when the committee moves to discuss any confidential matters, the live broadcast on YouTube will be cut. A reminder to anyone speaking today that your voice will only be audible online if the microphone is switched on, so please remember to use the microphones. Fire alarm, we're not expecting a fire drill, so if the fire alarm goes off, please follow officers to the fire exits and out of the building to the designated meeting points. There's more. Mobile and tablet devices, so for those of us in the room, please switch off any mobile devices before the meeting starts or put them on silent. Please note that councillors on the committee may use their laptops or tablets during the meeting to view any agenda paperwork. Residents' feedback forms. If you are so minded, can you please complete one of the orange residents' feedback forms? The information on those forms is intended to help us improve the way that we run our meetings. Forms can be completed and left in this room for collection after the meeting, or completed and returned by post to the address on the form. If you're watching on YouTube, you can also complete the form online, and there is a link below the broadcast. Declarations of interest. Please ensure that you identify which item you have an interest in, state whether your interest is pecuniary or not pecuniary, and give the reason that you have an interest. Members need not declare an interest in any item on the agenda where they have already listed this interest on the register of interests. Furthermore, you do not need to declare an interest just because you are, for example, a ward councillor. And then lastly, moving to part two, if we have a part two, we will now finish the public part of the meeting, and I'll make a statement at that point to alert everyone. Okay, so thank you for those of you attending this Health and Wellbeing Board meeting and watching online. So moving on to the agenda, I'll just check, are there any other declarations of interest from the room? No. And any apologies?
Chairman, we've had apologies from Nick Hunt from Royal Brompton, Graham Call, Vanessa Rodlin's here as his substitute, and from Eddie Yarn.
Thank you. So moving on then to approving the minutes of the meeting on the 22nd of March. We'll do a quick page turn. So any comments for page 1? For page 2? Page 3? Page 4? Page 5? Page 6? Page 7? Page 8? And page 9? No, thank you very much. So we will record those as agreed. And then, just to confirm, any of the items of business marked Part 1, as we said, will be considered in public, anything marked Part 2 in private. So with that, I think we're moving on to our first item, paper, which is on integrated neighbourhood working. And Ian, I think this is over to you to take us through.
Okay, hopefully you're ready. Okay, sorry about that. So hopefully you'll read this. Just going through with the highlights. I think on slide 2 it gives people an overview of how our PCNs are geographically located. You'll see in the north they're fairly discrete, with a couple of practices a bit in the Ruislip area, but in the south they're much more intermingled. And that probably just reflects the relationships between the practices within the PCNs and how they've chosen to work together. Moving down, I think the key thing about the Care Connection teams is that the success that they've had in reducing A&E admissions, about 440 attendances and 282 admissions, which is not insignificant, which has a £1.25 million gross saving at a rough back of the envelope calculation. And you can see also the demographic breakdown, basically in terms of fitness, which isn't really surprising. We've also been developing our integrated paediatric clinics, where the paediatricians from the hospital come out and sit and work with our GPs. and this provides an excellent community setting. It's convenient for the patients because they can actually turn up to their local practices rather than run the gauntlet of Hillingdon Hospital car park, and it builds relationships between the consultants and the GPs, as well as being an important learning experience for them. And we're going to expand that and widen that as much as possible to involve MDTs and mental health issues. And I think mental health is a particular focus for the CCT, for the borough as a whole over the next year or two. We're also we have embarked on a study to look at our population health and preventive care, and in fact that's going to be part of a whole, actually NHS and North West London wide initiative called Care 20+5, where we really focus on the 20% of the most deprived and also the 5 key areas of healthcare. And again, I think you have to put into perspective, over the past 2 years really, a lot of the services have been impacted by COVID, but despite that, the primary care teams and community teams have been working in an integrated way to monitor their diabetic patients and also enrol them in this Rewind project, which is aimed at trying to reverse diabetes by significant weight loss, which has had quite impressive results if patients can stick to the diet. And another area that we are focusing on is learning disabilities and complex mental health needs. And as you can see from the graph, the numbers of these patients who were managed to do an annual review of has increased steadily despite COVID, and we're going to increase and try and cover even more patients for the coming year. COVID vaccinations was a real success in Hillingdon. We were the highest borough for the first jab and the second highest overall, and similarly for flu vaccinations, I think we were the highest borough in North West London. We had access to winter access funding, which helped set up various initiatives to reduce numbers of patients going to A&E and setting up what we call surge clinics for general practice for the patients to be seen. And we offered 106,000 more appointments last year than we did in the 2019-20 year. Enhanced access requirements. There's a new enhanced access requirement, part of the primary care network DES, to double the number of hours that are available outside the core hours of general practice, and primary care networks are currently working up plans to get this going, including a patient involvement and engagement process. We've also been working with HHCP to set up various community clinics in gynecology. We've got what's called a coil and pressure clinic that we're going to extend and also widen the scope of. We had a COVID urgent eye service which has come to an end, and in fact wasn't widely taken up, so the impact won't be that great. Gastroenterology, we've set up a process to focus on those patients who've got irritable bowel and celiac disease in particular, and that concludes the summary of what we've been doing with our integrated care in Hillingdon.
Thanks, Ian. And I think reading through all of these papers, there are some key themes that start coming through in terms of how we are sort of using our teams to work together and deliver against some of these outcomes. So I'll open up to anyone who's got any questions on the report. There's some great headlines. Kelly.
Lovely. One of the things that we've been trying to look at through the system partners is to look at variation across the borough and to start thinking about how do we develop data that really identifies of areas of highest need and areas of unmet need. So as we start putting these sort of areas together, are we amalgamating that information in order to sort of really inform some local place-based practice, particularly where it needs weighted resources to those areas?
So every primary care network has been tasked with appointing a lead who is tasked with looking at variability and difficulty of access to patients, and that plan's then going into the borough where it's going to be collated. So yes, we are.
Anything from anyone else? It leads quite nicely into the next agenda item, actually, doesn't it? I suppose in terms of population health. Lynn.
Sorry, Caroline. Yeah, Ian. So one of the things, one of the biggest things that our patients are telling us at Health Watch are they don't like e-consult and digital GP access, and there is, significant evidence of exclusion of certain groups. How are we tackling that as a neighbourhood?
Yeah. So I think it's a mixed picture, Lynn, because the younger workers say they actually do like it, it's more convenient, but clearly for the older, the frailer, and possibly ones who have more health needs, then it is more difficult. Hillingdon, as part of a North West London procurement process, has procured a more modern e-consult offering, which is being launched, actually in my practice, next week, and then rolled out to the rest of the practices around Hillingdon. That doesn't get around the problem of the actual digital inclusion-exclusion. And I think we're very much in the foothills of learning about how to do this. And personally, my own view is that anybody who is really over 75 and has certain conditions will see straight away face-to-face. I think I think we're going to learn which our residents shouldn't go through the online consulting. But the problem is we've got a lot of backlog to get through, and actually it's a much more efficient way of seeing patients. So, for instance, yesterday I saw 45 patients out in the afternoon because I could do that, bringing in those who needed to. And I think over the next 6 months to a year, we're going to have a little settling and a better understanding, because we're clearly in a transition phase, and also the online consulting software is not really very sophisticated, and again that will do that. So we do listen, and we're in a transition phase, and I think we'll have to get some more communications out from the CG, both to the practices about best practice about how to use it, and also to the patients about how to navigate their way through that. I mean, navigating the way through the NHS is a difficult task anyway. I don't think this has made it easier, so I agree with that. Yeah.
Thank you.
Any other questions, Councillor O'Brien?
Ian, could I just make a comment to that with regard to the e-consult thing? So clearly, I mean, there is some form of blended approach is the right way forward, and I fully appreciate that the Confederation are transitioning. I suppose from somebody who embraces digital and who's not over 75, and somebody who is not under 35 as well, where I'm sitting in my world now is probably, well, I can say that I'm almost being bombarded with text messages. So I don't know whether that's obviously everyone just trying to get up to speed, or if that, I'm just going to talk to you about, there's a consultation that I've just received recently. They've asked me to have a health check, if I could fill in a survey, if I could, I think I've had about 5 or 6 text messages, also just from the NHS or via the GP surgery, and without us actually wanting to press the button and say, no more communications please. How do you think that moving forwards we're going to address that with, obviously, with the user's peace of mind being thought through, as well as just the Confederation, please?
I mean, that's a very good point. I think in part it reflects the workload that's being put upon general practice. They're being asked to do more and more and collect more and more data, because people can look at this data more and more ways. So the more the ways we can look at data, the more we're being asked to collect it, and that's ending up with us sending text messages, because that's the most effective way for general practice to do it. Before this came about, we didn't have anywhere near as good a contact with our patients, so it's a double-edged sword, and I suppose we do have to prioritise, but part of it is feeding the beast of the NHS. They want this data, and unless we can actually improve our understanding of how the NHS works and actually have some influence on collecting only necessary data, then it's going to be difficult in the short term. Unfortunately, patients are going to be bombarded. There are increasing sort of KPIs to do this in so many times a year and more frequently, and then check up this, that, and the other. I think we're in a state now, just because we can do it, we're asked to do it, as opposed to saying, well, is it useful doing it? And the NHS is not in a particularly good listening mode at the moment.
And just to make one more comment to that makes perfect sense, and I think that what we're always talking about with our officers is, within Hillingdon, is that, yeah, the data's great, but what are we doing with the data? You know, Naveed's over there spends his whole life doing data, you know, but then how much do we actually use it? And I suppose what the gap that you are missing when you're sending those messages out are still to those over 75s who don't have a mobile phone, or even those that do but don't do texts. They just say hello and goodbye. How are we capturing their data? And, you know, what is it that, because they're the higher end of the spectrum, whereby they need you to know just as much as everybody else does.
So pre-COVID, the CCG tackled that by we had outreach of engagement sessions, went round to each locality, and again that captures those who will turn up. I have to say the numbers weren't great when we did those, and that's a perennial problem about how to reach those. I suppose there are things we need to look at, because some of the frail elderly will be visited by social services, some by community nurses, and also as part of the HHCP strategy, we're going to focus on the frail and the elderly to see what we can do with those and engage in a more sophisticated way.
Councillor Palmer.
Thank you, Caroline. I don't have any questions. I just want to make an observation, really, that some of the information in here is a shining example of the partnership working. And I suppose I want to say thank you to our health colleagues who've enabled this to happen within our borough, so that our residents are clearly getting the service they need. And I would hope to see this continue over the next few months. And particularly Aggie the Alien is a shining example of how we liaise with the residents that need the services. So I just think that this is great. There's a long way to go with it, but this is a very, very good start. So it's a big thank you from me.
Not at all. Aggie's a worldwide, London-wide fame now, and I think I suppose that's one of the few positives of COVID, that we've started working so much better together. Not just with our health partners, but with our local authority partners as well. And with that continue.
Any other comments, members? No? Okay, thank you very much. So moving on to the next item, which I think we might see some recurring themes, are population health programmes. So I think, Kelly, you're going to kick off with this one, and I'll chip in as well.
Yes, I will. And somebody's kindly left me. Oh, click the slider on the. Okay. We have a green light. Perfect. So, many of you will be familiar with this work. It feels as if it's been going on for a very, very long time, possibly because it has been. It's been stopped and started, and we're back on track now. So the context of this is North West London CCG commissioned Optum to carry out some population health projects in each of the North West London localities. All 8 boroughs have a PCN PCN level project. Well, what I'm going to talk about is the one that makes us distinct. It is the place-based project that we're the only one in North West London that are doing. So this is a sort of a big ticket piece of work that we've been doing. Now, the really clear thing, and just picking up on what you were just saying, Councillor Palmer, this is an absolute system-based approach. So this is a complex problem that no one organisation would be able to deliver in a sustainable way. And actually it really demonstrates that the different skills of the different organisations brought together can achieve so much more, because there's varied perspectives, various views, and actually there's been some differences of opinion, but actually what we've done is gone through a very robust, systematic process in order to get to the point at which we're about to sort of identify and agree some interventions that we're going to put in place. So this is the work to date. Okay. So the population health ambition is part of a sort of population health management toolkit that was sort of previously produced, I think initially by the West Midlands. And what it aims to achieve is the why and the how. So to improve population health, and there's sort of 5 areas where population health has really been focused towards. It's about better experience of care, improving the health and well-being of the population, and for this particular piece of work it's a defined population. To address health and care inequality, so these tend to be, say, people with more complex needs, people who are using health services and wider statutory services in a different way, to increase the well-being engagement of the workforce so that together we tackle this problem at a system level. And no doubt, obviously, we have finite resources. It's about also trying to make more effective use of the health and social care resources that we have in the borough. And actually, the way that this is set up is it's very much a learning approach to driving health and care services, and using that not just, and when I talk about health and care services, we're also talking about the wider determinants that impact on health. So not just about the NHS and not just about social care, but actually for this particular project, how we've brought in experience officer engagement, how we've looked at housing, and how we've looked at sort of how the environment impacts on this particular group of people. So the picture at the bottom, which is a little bit stretched, sets out sort of 5 stages of this process. Now, that 5 stages was originally brought together by the King's Fund, but actually what we've gone through is this really, really systematic process of sort of action learning sets, of which there's 6, and then intermittent between that, there is task groups to drive much of the process forward, because one of the things that we've really found very obvious right from the outset is that the action learning that sets themselves allow us to talk about the process and allow us to progress the process, but actually it's not as good a discussion forum as that which we get outside of that environment. And my goodness, it's generated a huge amount of discussion. And just to sort of name check someone, Melanie Foodie from the CCG has been the project lead on this, and I wouldn't want to do that job really that she's done, because she has just been onto this, bringing people together, driving the agenda forward, and actually trying to make sense of the ideas that people have put together. So this slide, and you've got a pack, just sets out what the action learning sets have aimed to achieve. So it looks at the current state, the future state, and the impact and implementation by asking us to what's the problem that we're trying to solve, and we've used that, identified that problem by aligning data sets of those people that are most vulnerable in the community, and I make no excuse for that, those people that cost the system a significant amount of money, and also to think about how do we make more effective use of our service provision to really target those people's needs. So we've identified our cohort, and I explain who the cohort is as we move forward, and we've gone through looking at those people that are affected by a number of different variables, which is where the aligning of the data sets have been absolutely key, and also to think about what do those aligned data sets tell us, and also where's the gaps in that information. And one of the key gaps as we've gone through that process is about the insight, particularly the insight of our community and how we engage in that community. And Caroline will talk about what our learning has been to date, and that is really possibly the #1 priority in terms of our learning and the gap that this process has had. but we've recognised that and actually stepped in it and intervened to address it. So part of the process then takes us through, so what are the outcomes we're going to achieve and what are the interventions that we need to put in place. And there's Action Learning Set 3 and Action Learning Set 4 is where the most of the discussion and most of the differences of opinion, how do we prioritise, has really taken place. And that has generated a huge number of outcomes that we've thought what's short, what's medium and what's long term, and also to think about, well, actually in order to achieve those outcomes, what are the interventions and what are the resources that we need. So that's where we are at the moment in terms of Action Learning Set 5. And if we move on to the data set, this is an example of the dashboard that we've used. And actually all we put this in the slide deck for is to illustrate the number of different variables that we've used to actually bring this to life. So this is a number of different data sets which we've aligned together in order to produce the summary of the cohorts that we most want to target. And actually much of the data set, and Optum have really been very clever in the way that they've brought those data, have all been RAG rated in terms of those number of variables which are really red or which are really amber. If we align them together, we generate this group that in many respects are similar in the way that they have specific needs, they're similar in the way that they're using health services, and they're similar in the way that they do cost the system a considerable amount of money. But also if we target them and put interventions in place in a more cost-effective and resource-friendly way, what could we do that's better than just this constant need for services that may or may not be helping them sufficiently? So, as I say, number of these different data sets, sort of cost-benefit or cost of the resources that are currently targeted towards this different group, which then brings us into our cohort. So, Caroline, do you want to take over? Then just nod my way and I have the technology.
Thanks, Kelly. So you'll see in front of you we've got a kind of summary of the cohort which really articulates what you can see on the slide above with regards to the data. So where we found was about 1,500 people, so they were aged between 60 and 79 years, and they had a history of falls. One of the things that was really important was to be very clear about what the aim of what we were trying to do was, so we spent some time articulating that collectively, and that's the statement there, so to prevent falls and, very importantly, a recurrence of a fall, improve people's health and well-being, and for those that do fall, make a good recovery to maintain confidence and independence. So one of the key lessons, and we'll come on to this maybe in a bit later, was that the membership of the group and the work that we've done has been very much iterative as we've gone. So as we've started to refine the cohort, I suppose interestingly, sort of inversely, the group that we've been working with has grown because we've been able to be more specific about some of the people and some of their needs, and therefore grow the number of people that are involved in the conversations and involved in working through what those outcomes were, including residents themselves, and I'll come on to that in a second. So just in terms of the supporting activity that we've had in place, as Kelly says, it feels like it's already been going for a while, but because of COVID we've stopped and started a little bit. The data's been identified. We've got a strategy for falls prevention in place, along with some KPIs, and that actually ties really well into some work that we'd already been starting off around falls prevention. And we've agreed a decision support tool which is being piloted at the moment with some of our colleagues in care homes, and looking at a community falls prevention pathway and some training for our care home colleagues as well. I'm not going to go through this, you'll be very relieved to hear, but this really gives us an example of another part of the methodology, which is the logic model. So the aim of this is to try and stop people jumping to answers, which we're all very good at sometimes in the health service and in other professions, is we see a problem and we want to solve it and we want the answers. But what this really forced us to do was to start with the outcomes. So what are those longer term outcomes that we want to get to, and then work backwards, therefore, through what the outputs we might need to get to those outcomes, and then right the way back to the left-hand side, which gets you to the inputs, and you feed that through. So it was a really helpful discipline in terms of just trying to stop people jumping in with solutions. We still did our best to do that, but it was just helpful to challenge ourselves and take a step back. And then you'll see in big red letters at the bottom, and again I'll come onto this. So these, at the moment, this is a draft working set of outcomes, and some of the work we're doing around engagement is very much still in progress and continuing to give us insight and information on that. These are some of our sort of short-term, long-term and medium-term outcomes. I'll just really focus on the longer term. So where we're really trying to get to is promoting a positive view of ageing through actively engaging people to start thinking about self-care, plan as they continue through life, what we've termed an active third stage of life, skilled and empowered workforce, and people being independent for longer, and reduce the number of people who are avoidably housebound. And then you work backwards from that in terms of what you might want to put in place. We go on to the next one. So the next slide is around our interventions. And this was sort of group voted for, group developed, and again is still iterative. So I think one of the interesting observations here is that, as I say, we tried not to jump for answers, but there are still definitely some answers in here. Actually, with the help of colleagues, and Healthwatch have been incredibly valuable in this, so thank you in terms of some of the work we've done. Some of the stuff that crops up in the other activities, so things like use of aids, looking at aids, supporting people to plan, when we talk to residents, we're much higher up in terms of what they actually wanted to have access to than some of our things like a single point of assessment, which always feels like, you know, a nice kind of management process that we can put in place, but doesn't necessarily get to the root cause of what we're trying to prevent. So again, I think it's just an example of where we need to challenge ourselves and be as inclusive as possible when we're having some of these conversations about what we might need to put in place and what we might need to do differently. So just flipping over to the next one. So what we've learned, and yes, the point is so far, because the learning continues on the Hillingdon Place work stream. Plenty of time to reflect, and although it has felt like quite a kind of intense period of work, I think colleagues and particularly Melanie, as Kelly mentioned, have been really good at just challenging and saying, is this right? Are we doing this in the most effective way? What else can we think about, particularly when we came to things around engagement? Engagement is on there in bright red because it is fundamental to all of the work that we're doing, and I think comes back to some of the conversations we were having earlier about not just taking information for information's sake, actually going out, engaging with people, having a conversation and thinking about how we build some of that into some of our approaches, our solutions, and our longer term plans. So it needs to be from the outset planned into the process. As I say, we've used a variety of engagement methods. We've had one-on-one interviews, we've had surveys go out, we've gone through services, so we're continuing to do that and continue those conversations as broadly as possible. The data is invaluable. I suppose the only thing I would say about data is you can sometimes drown in data, so it's being clear about what are the questions that we're asking of the data and bringing in the qualitative side with the quantitative side, so that we can look at what people are telling us alongside all of the great spreadsheets and maps, so that we can really make the best use of the insights that come through that. And then thinking really through the interventions and recognising that we need to tweak those depending on what people's needs. The last point there is that it is really quite a resource-intensive approach, as you've probably picked up from the way that Kelly and I have described it. It definitely has a level of momentum, it takes time, and I think one of the things that we need to think about now in terms of how we sustain this or think about really embedding the principles and the approach in the work that we're doing more generally is how do we have a pragmatic approach to taking the good stuff that comes from the work and the learning, but without necessarily having the level of resource and input that we've had over, I think it's 22 weeks of the entirety of the programme, and it's been 10 weeks so far. So we will have to think about how we do that practically going forward. Is there anything you wanted to add, Kelly, before we open up?
No, I when you said 10 weeks, it feels like so much more, doesn't it? It is a really, really good programme, but I can't emphasise it. The amount of need that we've got in most areas is, if we focus on 1,500 people in this way, then and use all the resources in order to deal with 1,500 people, what about the other 300,000 people who may have different needs, but actually we're not tackling those? So as a proof of concept, so far, it's great. But I do think we do need to think about something that's slicker, something that moves faster, and possibly how do we get this to be business as usual? Because it's systematic, it is informed, and it is requiring a system think and a system approach to it, which are all the things that HHCP have been doing, for a number of years. But yeah, it needs to be a bit slicker.
Thank you. Any questions from anyone? Patricia?
So it's not really a question, it's more of an observation. So first of all, I think this is a really good piece of work, and in a way I don't think you should beat yourselves up, because actually it's proof of concept. I can absolutely see how using Falls as the sample area, actually you should be able to take the lessons learned from this and translate it across to other areas. I think the thing that is interesting is the other activities, and actually I'm not surprised about the issues around AIDS and psychological aspects of this, because and I don't think we should underestimate that in the population. I think a lot of population health issues are not about necessarily making a medical or a care intervention. It's about allowing the population to take some control of their illness and actually support families to help them in as much as, I think of my parents' generation, who don't want to admit that they're old and frail, but actually just some sensible advice about the sorts of things they could do to stop them from falling would make a massive difference. But they don't want to hear it from me, their daughter, but I kind of need to know where I can go to find somebody who will tell them that. And the other thing I wonder here is, in terms of this being ongoing, where are the other places that we could place some of this? So I'm thinking, could we be using community pharmacies more, or organisations that supply compliance aids to make those things more available to the public? Because not every member of the public will be able to afford these things, but there will be people who can, but they often don't know where to go and access that. And I do think that there are high street alternatives. AIDS UK is a good example. If they had a series of aids available, kind of kite marked in their various shops, or it was a link with local pharmacies or whatever, I wonder whether we could actually build it into every day and not make it quite so resource intensive, because it came part of another service offering.
I was just going to say absolutely. I mean, AIDS UK are actually one of our partners on the group, and I think it was really interesting gathering that feedback from residents, exactly as you said, the broader scope of issues that impacted people. So even just the understanding of what might be a risk in their own home, they wanted more information about it, but it wasn't really clear necessarily where they could get it from. So I think the breadth of support and ideally non-clinical, non-medical support that we can get out there is definitely great. And the other thing that was really interesting was the use of language around it as well, talking about where people take their information from and want to hear information. There was a marked difference in terms of how people felt having fallen as they became more frail, in terms of the level possibly of embarrassment and not wanting to tell people, which obviously then leads to a risk of a second fall. So just having the ability to destigmatise that issue and get people the help as early as possible. So yeah, absolutely. Kelly, I don't know if you wanted to.
Yeah, I mean, I think in terms of the process, we have started some engagement. There has been a very short window to really do it effectively, but actually what's been achieved in that incredible, I think it's been about 2 weeks, isn't it? What has been achieved is just phenomenal. I think what I think a part of the process, on reflection, is we created our views of what people needed. So that list of who voted for what was basically, as professionals, we're not asking anybody. We know best, because this is a process. And it was that like road, I won't say road to Damascus, nobody wants to be on a road to Damascus, but actually that moment, that light bulb moment where we suddenly said, well, actually we haven't asked anybody. We haven't even consulted anyone. We haven't spoken to anyone. And initially, the initial findings that we've had from the engagement is just, absolutely sort of wipes out of the water some of the preconceived perceptions that we had about what people's experiences are. Not least because I think, you know, some of the work that you've done previously in terms of wider health watch work in North West London, people don't recognise that they're frail, and actually people don't. What's the definition of frailty? And I think one of your organisation's documents refer to it as the ability to bounce back. And I think when you look at falls, the ability to bounce back, particularly in that older group, it means that a fall can be a significant incident for somebody. And actually, particularly this group, there was a significant number of people that were housebound. Now, if that was triggered by a fall, you can understand that loss of confidence, that feeling that somehow that they were incredibly vulnerable, and actually that led to a quality of life that was costly for us as services, but even more costly for them and their families in terms of, you know, what health and well-being that they were achieving. So there are so many variables that I think a wider consultation will draw out of it, which may help us to reframe what our interventions and possibly what some of our outcomes are going to be going forward. And picking this piece of work up, I think one of the things that we did from the outset was vote on. It was this particular project on sort of unplanned chest pain for younger, well, middle-aged men, younger than me, but young. Sorry, that just turned up to A&E departments. So actually, I think we're segueing into that new population health cohort and thinking about how do we apply it to a different group where, again, the needs will be very different, the ability to engage with them will again be different. So it's great from that perspective.
Councillor Palmer.
Thank you, Caroline. Yes, I want to agree with Patricia, really. I suppose I think this is a really good piece of work, and I do agree with what's been said there about the falls. If we can use it as that, then we can use it for anything. I was also struck by the other activities, and I think what this shows to me is that we can't underestimate the emotional support that people need in order to do any of this. And with preventative work, I think what we do sometimes in our voluntary sector, and I do speak from experience as well as our social care, is we solve the problem, but we don't always get in early enough, because when you come into the voluntary sector, you want somebody to listen to you. You want something fixed, but you also want to be able to do it yourself next time. Nobody wants to be able to have everything done to them all the time. So I think for me, it is about how are we going to use this to find the good old-fashioned way of helping people who don't have families, who don't have a next-door neighbour, who don't have anyone. What are we doing with this invisible community that we don't see? So for me, this is very, very important. The emotional support and the mental health that's probably not written into this, but I know we all know it's there. Thank you.
Yeah. So, Councillor, the long-term objectives that we put into the presentation really reflect that there needs to be a change in culture. There needs to be a way that we really target or get it's a universal approach, because actually one of the indicators that we had on the first sheet is that unlike some of our other areas of healthcare need, this is not deprivation-led. This is applicable across all deprivation scales. So actually, if we can get sort of society, let's start with our borough, thinking about how do we promote a positive view of ageing, because most of us will be part of that. You know, we'll all get there at some point, but how do we get people to a position where they engage with self-care interventions, they start thinking about what's the accommodation that they have as they move to sort of older age, and and actually when you start thinking about this, older people in accommodation that actually is really not relevant to what they need, and start thinking about that this is just about adapting for a different stage of your life so that you can stay at home longer, because most people want to be at home longer. Nobody really chooses to go into a care home, and as you get older, that risk is greater if you start living on what's the phrase when you talk about single level, if you don't live on single level accommodation? What do we call double level accommodation? Houses. Upstairs. Oh, good. I've learned something.
Ian.
So I mean, building on that, I thought one of the things that possibly needs to be brought out a bit more in this, I thought it was very good, is the intergenerational work. And I think starting really at primary school level. I mean, there are all sorts of initiatives of classes going into care homes and engaging with the elderly there, but I mean that could be extended. I think the other thing, again, is a bit problem solving, is setting up schemes whereby elderly and frail who live on their own and have spare capacity in their houses can actually put up students. There are schemes around the country and around Europe particularly where the accommodation is subsidised if they act as a sort of some sort of carer in an official capacity to do that. I mean, we've got Brunel here. The students may need some accommodation or other accommodation issues need to think about. So the intergenerational and getting the younger people to understand what it's like to be old and to engage with them rather than just stand off, I think is going to be very important.
No, that's a really good call. There was a recent article, and I can't remember which newspaper it was in, about intergenerational, because we tend to put older people into an environment where there's just other older people. So actually, it's about, that's not what society is about. So how do you create a sort of a sub-society in an area that represents that with different age groups? Now, you know, as a mother of a student, I wouldn't want to live next door to her in her house, but you can understand that actually it's nice when people live next door to sort of a family when you're an older person. And some of the work that my team are doing and with across Hounslow and Hillingdon is looking at asset-based community development and that particular work and how do we apply that locally. And so watch this space, because I think that actually if we think about what are the assets in our community and how can we make that happen, and how can people, you know, sort of young people be ever more present in older people's life, will absolutely change the way that old people or society view different generations and them being separate to each other.
Patricia.
Can I just pick up that bit about asset-based communities? Because I actually think that the longer-term outcome shouldn't be a skilled and empowered workforce. It should be a skilled and empowered population, because we rely too much on it's got to be a workforce that know what to do, but actually what we need is a population who know what to do with a skilled workforce that when they need health or care intervention, that health and care intervention can apply and work with the person. And I think that's where, you know, we can use the asset-based piece, because our more local population could help with some of that because they know it and the older person knows it and knows what they want. And I think that's the bit we've kind of forgotten. And I think some of the stuff about the old and the young intervention, picking up Councillor Palmer's point about older people feeling embarrassed, you know, you wouldn't get my mum to use a stick for love nor money, and she lives on a farm and really should be using a stick because she coggles her way across it. But if I had got her sorted out with some trendy walking poles 10 years ago, she wouldn't be at risk of falling because she'd just get them out every time she went out and about. And there's some, and actually if my niece or nephew said to her, Granny, why don't you use these poles and we're going to come out with you, it would change that whole modus operandi because it'd be trendy rather than I'm old and I need a stick. And I just think there's lots of stuff that we could do in a very different way and use that local asset.
I think what you've highlighted, and we're quite new to asset-based community development, I think that's worth having a proper look at, because those assets are out there, we just don't know that they're there. We know where some of them are, but not all of them, and actually sort of motivating that move towards helping your wider community. They're all those community connectors, those people are all out there, so we just need to capture that one. Yeah, thank you.
Lynn,
Thank you. Just really to kind of follow on 2 points. The first one that Kelly mentioned, that we've been doing this work now for a couple of weeks and we've had about 30 responses back to the survey
but we've had some very rich data from a number of direct interviews that we've done from people that have actually sustained a fall. And one of the things that we hear over and over again is they don't want to be a burden. It's a really common theme running through what people are telling us. And secondly, that I don't know whether I'm jumping the gun here, but we've started now to undertake some direct interviews for patients on end-of-care life pathways and relatives, because I think, as somebody else mentioned, this is a model that can be replicated in other areas, and possibly that may be one of them going forward, which I think will be excellent.
And just to echo, thank you to the team as well, because they've done a fantastic job in a very short space of time, and it's really made a difference. So, absolutely. Vanessa.
Thanks, and it's an amazing piece of work and something we're particularly interested in CNWL. So I know that we've got to catch up, I think, about the community collaboration work that we want to do in Hillingdon. I just wonder if we can think then about how we join those pieces of work together, because one of the things we're looking at is how do you find people who maybe can't reach the services in Hillingdon. So this might be something we can join up together with.
Okay. Thank you very much, everyone. So there are some real themes developing through both the work that we're doing and through the conversation we've just had, which, as we said, what we're keen to do is think about how we take that forward into population health management more generally. So all of the pieces we've talked around asset-based development, thinking about how we engage and work with our residents differently, and sort of use the data and the qualitative information together, gives us a model, I think, for what we might want to do next. And so I'm sure at a subsequent meeting we will both bring back an update on the work in this context, but also what we would be looking to do in the future with population health management. Okay, so moving on to the Integrated Health and Care Performance Report. Gary, is this over to you? Thank you.
Thank you, Chairman. Just a few points to highlight. Starting off with the 21-22 end of year template. This is something that all Health and Wellbeing Board areas were required to do. We have submitted as a draft, pending approval by the board. Hopefully the board will agree that the overall message is a positive one. We're green on all barring one of the metrics, and the one metric that we're not green on is where the data is not available, and we were green on all the data that was available. I think some of the key challenges that have been highlighted within the return actually relate to workforce and position within the care market, often actually very much interrelated. I don't know, Chairman, whether I actually want to stop at that point just to see whether the board has any questions about the actual template.
No.
It would appear not, Chairman.
No.
In which case, moving on to the 22-23 BCF plan development, stated in the report, intelligence from NHS England suggests that publication of the planning requirements will occur at about the middle of July. Latest discussion suggests that may slip further. I've set out in the report what we knew at the time about the requirements. Since then, I understand that additional requirements are likely to be around addressing health inequalities, which obviously the work that's underway that we've discussed already would feed into, and also supporting carers, which I think Hillingdon is quite strong on. The other point I wanted to highlight is actually around the adult social care funding reforms, which are sort of set out in the report, sort of highlighting the intention to increase capital thresholds and introduce a care cap, the overall effect of which will be to increase the number of people eligible for adult social care support from the local authority. Linked to that is an identification of fair cost of care exercise being done which will determine the cost that should actually contribute to the care cap. This is on the premise that government regards there to be an unfair differential between prices paid by self-funders and local authorities. That exercise is underway at the moment. The exact impact on the market is uncertain, and we will feed back to the board once more information is available. Certainly, there will certainly be an impact. Those are the only points I really wanted to highlight, Chairman, but of course if the board have any questions or queries about other aspects of the report, happy to take.
So I had one which wasn't so much a question, but just in terms of that point around the differential costs of care, and because one of the things we've done recently was something that we've been keen to do for years in Hillingdon, which was bring the brokerage together of the care. So we've now got health and social care being brokered, and which was really to remove some of those differentials that we're paying across health and social care. So I suppose it was really just a question, not in the specifics obviously, because I know people are working through that, but more about the process of how we do that across health and social care, to identify what the risk and potential impact is on both partners, and presumably that's across, that's going to be nationwide, so it's something we're going to have to pick up collectively and probably within the ICS. Do you want to?
Yes, Chairman. I think my theory is that it could impact or negatively on NHS rates as providers seek to recover higher costs from the NHS. But again, that's speculation, and we need to go through the exercise and see what happens at the other end of it.
Ian.
Gary, I was particularly interested by the end-of-life data, and wondered what West London was doing that made it so effective. Is it data accuracy? Is it a small numbers game, or is it something they're actually doing that we could actually emulate and get some benefit from? Because they've halved their numbers of emergency admissions the last year of life from 15% to 8%, and the numbers who are expected to die at home are the best in North West London. I mean, we're not doing too badly, but they're clearly doing something that's even better that possibly we could learn from.
That's one that I'll have to take back, Chairman. I don't know the answer to that.
Any other questions on any of the elements in the performance report? Mr. Brown?
I know that we're probably going to take a little bit of this offline still as we're working through this work stream 5. It would be remiss of me not to mention children and young people within this. And I think, just going through the data, going through this paperwork in connection with the holiday and food programme. I know that it's mentioned in here, and I know that it has worked very successfully within Hillingdon. Did we monitor any of the points that we're asking about? Were the children eating a little bit more healthier over the school holidays? How much more active were they with regards to the activities that they were taking on board? Some of them were cooking classes, yet some of them may have been playing football. Was there any, not that I want to pull data in anymore because I know you've got loads going on, but did we do any of that type of monitoring while we were going through the programme?
I'll have a go at that one. I think I'm pretty sure we did. I've seen a report on the HAF, you may have seen it yourself. And I know the team collected an awful lot of data when they ran out the first pilot, and all of that is informing the learning for the next session. So I would suggest you do take that offline and make sure I give you an emphatic answer rather than a sort of an assumption. But I'd be surprised if there wasn't the sort of data you're asking for, because it's exactly the sort of thing they've been collecting. So I would hope that would be a key part of taking this work forward. Yeah.
Yeah, and as we were talking about Aggie earlier, Aggie's part of the SMILE programme, as Councillor Dennis has just done the review last year. I'd like to see Aggie a little bit more involved within SMILE, as well that she's been taken up with vaccinations. I'd like to have her looking at people's teeth a little bit more and more frequently. I know that we've got numbers down here, but that is still very core in the world of children. If you don't have teeth, you can't smile, and you can't eat, and you eat rubbish, and that needs to be changed. Thank you.
Although I think Aggie's only got one tooth, so I think she's...
That's why she's...
Anything. The only thing I was going to just draw a bit of a link towards, because I think we had it at a previous meeting, is some of the activity information in here. We're also triangulating with the work that's going on around the outline business case for the new hospital build. So just to, I suppose, give a little bit of assurance and connection that there's a lot of work happening at the moment, just to go back and look at, so when we're talking about some of the emergency admissions, A&E attendances, and some of the work that was referenced previously around some of the outpatients and planned care piece, all of that also ties into the work around the outline business case for the new hospital too. So as much as we can, we're trying to pull all of those programmes together and work to a single set of metrics and a single set of activity assumptions. Is there anything else on this? No? No? Brilliant. Thank you very much, Gary.
Chairman.
The template, yes. There weren't any questions on the template. Sorry, yeah. I think I'm going to speak now or forever hold. No. Okay. Thank you. So moving on, I think it's the crisis update next. So to Vanessa, thanks.
Thank you. So this, hopefully people have had an opportunity to read through. So this is an update from the last Health and Wellbeing Board. So this is in relation to the mental health crisis pathway for those people 18 and over. So there's the few bits that I want to draw people's attention to. The kind of most positive one that I want to draw your attention to is the crisis house that we have established alongside the local authority and Comfort Care as a provider to provide a crisis house for residents in Hillingdon. That's due to open the first week of August, so I do want to say thank you to partner colleagues, because actually that's been a really big piece of work that's actually happened very quickly this year. So fingers crossed that will really, I think, support the crisis pathway and some of the challenges that we're facing with mental health crisis in Hillingdon. The second part that I want to talk about is the Coves Cafe that I talked about at the last Health and Wellbeing Board. So subsequent to the last Health and Wellbeing Board, the comms from both Hestia and CNWL have done quite a bit of social media presence around the Coves. That has seen a small increase in numbers. I think we went up to 70 in March 2022. What we haven't seen is the increase that we were looking for in terms of presentations. I do want to say, though, that we are the best across all of the boroughs in North West London and Hillingdon in terms of presentations, but we are wanting to see a significant amount more, probably double the amount that we saw in March, so really wanting to see up to 140 presentations. So the other things that we have already done post this report and things that we're planning on doing. So we have shared out the communications and information with the ambulance service, the Met Police, the Heathrow hotels is one of the ideas that we've talked about this week. And we are now looking at doing a video, so actually wanting to talk to a resident who's used the Crisis Cove Cafe to share with them how helpful it was. You know, so we have words which is helpful to have in leaflets, but actually hearing from someone that's used the Cove Cafe would be particularly helpful to kind of get out there and share that it is a useful place to use for people. The other thing that we wanted to look at, that we've started to look at in the last couple of weeks with the Hillingdon Hospital, is we know that crisis presentations in A&E have increased. Our admissions to mental health, they don't convert into admissions to mental health wards. So what we know is we're seeing obviously this increase in demand. We are talking to the Coves about actually having some of the Coves staff actually basing themselves either in A&E or at the urgent care treatment centre. So I've got a walk around with Tina Benson, the COO from the Hillingdon Hospital, just to kind of try and understand where it would be best to position that extra resource so we can support people to actually, I mean, I'm thinking actually supporting those people to actually physically get down to the coves, because you can say go to the coves, but actually I think some people, actually we need to look at transport and supporting them to actually go down there. So that's one of the things that we're wanting to kind of ramp up and pilot very quickly. The other thing that's being piloted in Brent that I'm keen to do and start in Hillingdon is extending the coves to being 16 plus. So the Brent model has been piloting that for the last couple of months. It's been quite successful. Again, wanting to kind of start that over the next 3 months. The other place that we want to build this into is I guess really thinking about how our partners in Hillingdon can support us with getting the message out there. So I'm kind of thinking about Health Watch, maybe the social prescribers in primary care. So we have shared the details out with all of the statutory organisations and voluntary sector organisations. But any other ideas about how you think it would be helpful to get the message out there that the coves is there for people to access, to be referred to, and this is also open access. I'm all ears really. I think that's probably it from me, apart from the other kind of final thing very much linked to the presentation that Caroline and Kelly that you've presented around population health. There is something for me about how we tap into people who maybe aren't using our services. I wonder if there is an opportunity. I'm doing a bit of a walk around with some of our communities, so we've got some staff who are going to link me in and invite me into some of their community groups. So I'm going to talk to them about the coves, but I wonder if there is also another opportunity as part of the population health to think about how we kind of tap into the coves or our crisis services and linking that to the people who need it. Thank you.
Thanks, Vanessa. Ian?
That's just an answer to that ask. I just wonder whether it would work if you put some sort of link into COOF once you've worked out the over 16s.
Yeah, thank you, will do.
Councillor Palmer.
Thank you. Yes, thanks for this, Vanessa. Reassures me slightly from where I was last time with it. I suppose I've underlined here a wide advertising campaign. I'm not sure. Social media is great, but it's not the be-all and end-all, so I'm not sure I can concur with a wide advertising campaign until I know how wide it was. I've never seen anything. I've only ever seen one tweet, I think, or one Facebook thing, so I was expecting perhaps to see a much wider thing. And my observation at the last meeting was my concern at how the staff had behaved by not being as professional as they could be as people were coming through the door. I think you said to me that you were one-to-oneing and there was going to be training. Could I be satisfied that that has happened, and what happens at the door now are people are greeted in a more friendly way?
Yes, absolutely. So we picked that up immediately afterwards, and they've had further training. We've also got contract meetings where we're asking for the feedback, and as you can see from some of the comments, actually the feedback we're getting from people attending the coves is much more positive. I think one step further would be to actually speak to some of the people that are attending the coves, so getting their details so that they could be part of our I guess our video campaign. So we could do an advertising campaign, but I'd quite like to do a video with our comms to share out people's experiences in that way, which would also reassure.
Thank you. If I can just be cheeky and continue, I think support for this the 16 under. I think that that would have my support. I think that the earlier we can get into services like this, the better. And also for me, it's about where are these people that are struggling with their mental health that aren't coming through. So how are we going to look at getting help for these people that could be, I don't know where they are. Are they on street corners? Are they some of the people I see hanging about? Are they in their bedrooms? Where are they? But I would support the COOF link and anything we can do to go where young people go. And for me at the moment, that's a lot of street corner antisocial behaviour. That's not a criticism, that's just the observation of what I see. Are we in gyms? Where are we? And I think what we need to do is ask a young person, because I'm at the older age. I don't know where these young people are other than what I'm seeing. So are we using those people that are coming in? Because it's likely that they are mixing with people who have similar mental health concerns. Thank you.
So I'd refer back to the update in the previous paper in terms of the young adults. So we've got a number of new schemes that are coming up for young adults. So one is linking with within Brunel, and one of them is also making sure that we're linking in this piece of work to Brunel would be the first thing that we're doing, and the second piece is actually linking into the Hillingdon and Harrow colleges as well. So there we're developing a in-house counselling service there. So this is already at the top of the agenda to be part of there. So I very much want this to be part of the young adults pathway, so that it's part of that offer. It's not a standalone offer. It needs to be part, and it doesn't just need to be part of the young adults offer. It needs to be part of the offer for all adults. And I think that you're really right in terms of we can share and we can say something at an appointment about the Crisis Cove Cafe, but how do you actually get someone to want to go there? So there is something about how we actually pull people into that service, and there is something for me about getting the Coves to actually be, or Hestia to be part of that.
Lynn.
Thank you. Certainly we can use our social media networks to help you to get the message out there, but I think what would also be very helpful is that we're starting a round of works with the schools going forward, recruiting new members of Young Health Watch, and I think young people talking to young people is a very good way of getting the message out there. So certainly that's something that we could link in with you and help with.
There was a pilot a couple of years ago that Young Health Watch ran with mental health in schools. I think Kim did it at the time, so there may be someone who remembers that, because that was very valuable, and it was that peer-to-peer conversation.
So we're just about to repeat that as well. Lisa Taylor she's doing the dual role at the moment, but she's got a plan for rollout in schools and recruitment.
Councillor O'Brien.
Sorry, could I just respond to the offer from Lynn? Thank you, Lynn, that's really helpful, and we'll take you up on that offer. We do have a young adult also as part of our young adult pathway work, so someone who's used our services, if you want to kind of link in with that in terms of your work, happy to do that.
Thank you. Yes, I think you've obviously been given a few hints now to where to go to. I mean, there's also some of the community centres whereby they've got food banks, they've got dining clubs, all of those sort of outreach people that have already got a cohort of people that may actually need that little bit of extra support, and also the community like P3 Navigator and things like that. But I suppose, as I was thinking about these other organisations and linking in, and I think it's good that we're dropping the threshold from 18 plus to 16 plus. However, is the Cove the right place for 16-year-olds to turn up to? If we just, I'm not going to say that you need to have the safeguarding measures in place. You will have the safeguarding measures in place, but that's really quite high on my agenda. If you've got a very young, impressionable 16-year-old, then linking up with older people and adults, I just want that space to be right for them. And are you going to think about sort of segregating them slightly, or how's the mixing going to be? And I suppose as well, great that it goes with Couth and great that it goes with Young Health Watch, but are you capturing the same people just under different headers? And so whereby I would like it to be fruitful, you just don't want it to be a duplication of work, because that's where time is wasted and money is wasted, and I don't really want to say that out loud, but that's my feeling, because we know that resource is very finite and obviously very precious. But I'm openly embracing what the Cove is doing. Just obviously next time we're here, hopefully those numbers would have doubled again, and that's the hope, because it's the push that needed to still happen, I think, really.
So you're quite right on the kind of young path, or the young adult I guess pathway, and people using the Coves. I think it is in parts of the country there are services that are used and looking at kind of 16 upwards, and we would want to take obviously a view around risk when people are coming in through the front door, as I would want to do with all over 18 year old patients who where there might be a kind of similar difficult mix of residents coming through. So I think that is a fair point. I see this as part of a kind of jigsaw puzzle. So you're right, we don't want to be seeing the same people over and over again. We need to make sure that we're really clear in terms of how we're capturing the people that are coming through and making sure that they're going to the most appropriate place, because, as you say, as part of our young adult pathway, we've actually got a number of voluntary sector organisations providing other services and other supports. We want to make sure people go to the most appropriate place. This is very much for mental health, for people in a mental health crisis, and we would want to make sure that people then were signposted to other places if they actually weren't, or they were requiring something that wasn't necessarily a crisis. From my perspective, for this piece of work, I really wanted to support our A&E colleagues actually in the Hillingdon Hospital, because that's the place where we're currently seeing, and it's not getting any better. Actually, we're seeing people coming through the front door, so there feels like there's something not working. More than when I was sat here probably 3 or 4 months ago, there's something not quite working. There are people who aren't known, so I think it's 60%. So looking at the data, 60% of residents are not known to any NHS organisations, not to CNWR, coming in through the front door presenting in crisis. Admittedly, some are coming in maybe from Heathrow, so there are that cohort, but actually there's also a cohort of people who I think we need to reach before it gets to the crisis point and they're coming into A&E. But the best next thing that we can do is have someone there actually moving them to a safe space that isn't A&E, and they're being cared for and looked after, or a cup of tea and a kind of cooling down period.
Councillor Palmer.
Okay, so I suppose what I don't want to go away with today is the thought of what's not working. I can't go home tonight and think about those people that are not getting help because something isn't working. So I'm going to ask professionals, I mean, you've made the statement, what do you think is not working? Because that's quite a broad thing to say, and I'm quite uncomfortable with that. I sort of get what you're saying, but I need to understand it a little bit more.
So what we've seen an increase of people coming into A&E with mental health presentations, and so by me saying that something is not working, I think what I'm saying is we're seeing an increase in A&E, and there's something that we need to do about that. So what we're doing about that is making sure we can get someone from the Cove to come into A&E to support the psychiatric liaison team who are seeing those individuals, to ensure that if they're not to be admitted to a mental health unit, that they are getting support from elsewhere. And we're doing that. We want to do that immediately because we know we've got this resource to support the crisis, people who are in crisis. So it's absolutely not that I feel that there's something that isn't happening. What I'm saying is we're here saying this is what we're going to do in addition, because we've recognised this particular pressure in A&E.
Patricia, did you want to comment on that?
And if I can add to that, actually the work we've been doing with CNWL around this cohort of patients is actually has been a really positive interaction, and I think these patients are being cared for. It's just that the environment in A&E is not the best environment for them, and if we can have an intervention, so at the moment they're being cared for, and in extremis we will admit them, but actually what we want is something that says, your intervention isn't to be admitted, you don't have a medical problem, but actually how can we get you somewhere where it'll be a calmer environment, you're with people who can care for you. So actually this is really positive, I think, because I think we've identified something quickly, and I'm confident we'll be able to use this resource to nip this in the bud. And if we don't, then we'll have done something quickly that says, if that's not working, what else could we do?
Councillor O'Brien?
Just one last question, which I didn't have until you've both answered that one. Can I just ask then, in respect of the 16 to 18-year-olds that are possibly presenting at Hillingdon Hospital, are you having that? Are they bypassing CAMS? How are they ending up at A&E first? Or is it a last resort? Well, I'm assuming it's a last resort, but...
So my comment around the increases in A&E is in relation to 80 people who are 18 and over.
Thank you. So lots of work progressing, lots of ideas and things for us to take away, I think, as a system, and think about how we put something together. And I think also picks up the point we were talking about earlier with population health, in terms of how do we actually get some of that rich information from our population to find out, because in terms of things not working, I think what we're expressing is that A&E shouldn't be the first point of contact for people who are having a mental health crisis, and we need to have a think about what that means. Tony.
Thank you. I was sort of reflecting on a number of different points raised throughout the meeting, and I'll probably volunteer Kelly, but I'll have a discussion with later, because there's a theme about how we make people smart consumers of our system. And if we look at all of the work we talked about earlier about digital, I mean, some parts of that are kind of, fear and unknown and whatever. So actually, how do we help people become less fearful and more knowing about sort of what and how to use what is, pretty routine technology now. It's not like sort of cutting edge new thing, a smartphone and things like that, accepting that not everybody has them. But if we think about the services that we run as local authority, and we have access to the whole population of this borough through one means or another, and so we just probably need to think. So as I say, I haven't got an answer, it's just more sort of a thought process that I'll pick up with Kelly, just about how we sort of connect those to those different parts of the system, because we actually have the means to be able to do it, but then we do need to think about, well, what is it, what's the messaging? Because all of the work that we've been doing about sort of out-of-hospital support, and is that we know that people find a comfort in knowing there's a building that they can go along to. So, okay, how do we then, so we know that's the problem, so how do we therefore, what do we do to work on how we present something that's accessible enough for people to understand, no, there is an easier means by... Because we do know that through other areas, so the work that we did looking at the crisis house, for example, we know that where they're working well in other areas, actually people just take themselves there. Because once people know that these things are all sort of up and running. So, sorry, just a bit of a thought process really, but I will pick it up, because it's kind of silly that we're in this situation when we have the means to be able to access so many different channels from from preconception through to all ages, sort of up to adults. So I'll pick that up and have a chat with Kelly about it, and we'll try and coordinate some. It's not just comms, it is about the whole strategy of communication that we need to have a think about, I think.
I mean, we also had a similar conversation about children and young people the other day in terms of thinking about. So I think it's something that runs through all of the things that we're starting to think about with regards to population health. So that would be very helpful.
It's also the focus on prevention as well, because every time you talk about crisis, you think about what's the lead-in and what are we doing. And actually, if we were to think about what's the resources that we're currently using in that prevention space, and how do we move those resources, if it's insufficient, how do we move resources from the crisis point to the prevention and early intervention space? And actually, wouldn't that be so much better? Because in many respects, well, if a child has reached crisis, that's almost a failing on the system in general, isn't it? So happy to work with you and pick up whatever Tony's blue sky thinking is, and sort of feed that in.
Okay, thank you very much. So I think we're on to agenda item 9, which is the pharmaceutical needs assessment. So this is Naveed. Thank you.
Thank you, Chair. The board will recall that I attended in March to give an update on this piece of work that we kicked off early in the year. It's a statutory report that's required from all local authorities. It needs to be published by 1st of October. And I promised in the March meeting that I will be back with a further update just to keep the board apprised on developments. And the papers that you have in front of you today are actually the concluded piece of this work in its draft stage. So we've undertaken consultation with local residents, undertaken consultation with local pharmacies and the Pharmaceutical Committee as well, and drew their comments, but also completed the analysis as well in terms of the demographic analysis, the epidemiological analysis, and then an overview of what the pharmacies currently provide, and then have provided an assessment in terms of how effective and efficient that is in meeting resident needs. I won't go through all 160 pages of this, but if I just draw colleagues' attention to page 54 of the report, because there's a kind of summary in terms of what the key findings are listed in there. And so if I just kind of go through points 1 to 5 in the Roman numerals, the number of current providers of pharmaceutical services, the location where services are provided, the range of hours that are available means that the necessary essential services in terms of pharmacy provision are adequate and appropriate for Hillingdon. The number of pharmacies is also sufficient for our current population, but also our projections over the next 3 to 5 years. There is sufficient choice of both pharmacy provider and pharmacy services available to residents and also visitors into the borough. Obviously, being a landlocked borough, one thing that our residents do benefit from is the ability to access pharmacies either over the border, or if they're kind of commuting in and working in Hillingdon, to access kind of local provision, and that seems to be sufficient. One of the key bits of feedback we had from pharmacies was that they were more interested in taking on services, tendered services, if these were available to them. There are sufficient kind of in terms of the actual sort of settings. They've got consultation rooms, they've got other kind of appropriate sort of places to engage with our residents and offer services which aren't kind of provided currently. And there are opportunities for improvement or better access to current services and any new pharmaceutical services in the community, either through promoting what we have at the moment and maximising opportunities for health improvement and intervention, just that kind of enhanced role that pharmacies can play across the borough. There are 4 appendices that are listed. The first appendix is your overall pharmaceutical needs assessment and the kind of draft findings from that. The following 3 ones are the demographic analysis, as I said, the epidemiological analysis, and the pharmacy services. One thing to note from the demographic analysis is that our population projections are still based around the old ward boundaries, so we're still waiting for that detail to come through where we can start kind of replanning our demography based on the new ward boundaries. We will in fact be getting our first census outputs on the 28th of June, so that will be eagerly awaited. In terms of what I'm asking for the board is to note the work that's been undertaken so far, but importantly, this will now be subject to a 60-day consultation, and is to just get sign-off from the board that we are able to proceed with that.
Thank you, Naveed. So I had a question, and then I'll come to others, so slightly using Chair's prerogative. It was really fantastic, and actually all the demographic information in there was good to see as well. I just had a question about the 200-hour pharmacies in Heathrow and the impact that has, because although it therefore looks like that we've got a lot of provision in the Hayes and Hollington area, and particularly when you look at hours, and there was a map which I now can't find in here, but I did find it online, where we'd sort of mapped the usage of those, which looked like it was primarily workforce and people travelling in. I just wondered whether having those two pharmacies possibly skews some of the access data, or do we know that people in Heathrow villages and around there are going into Terminal 3 or Terminal 5, you know, bearing in mind, I think it's referenced in their car parking charges, and whether that's something that people would think to use.
So obviously we've done one of these previously as well, and that same point came up in the last time we did this. And one thing that we found when we were engaging local people was that people in Heathrow villages were much more likely to access it kind of further north, so into West Drayton and into Botswell and other parts of, rather than the ones that are local to kind of Heathrow specifically. So I think because our population, especially down the south, is much more mobile, they are able to access pharmacy provision, not necessarily within the locality they may be living.
Thank you, that's helpful. Kelly, thank you.
Yeah, just first of all, I'll start by saying well done to you and Kim, because this is painful to do, and it's you know, the process by which you go through is very prescribed, and yeah, so and takes a long period of time. But this is really excellent. I mean, you allowed me to go through it a little while ago. Had to remind me to go through it. But just picking up, Naveed, on the comment you made about access to pharmacies and just joining some dots up. So at the Family Select Committee a couple of months ago, there was a real drive to, so what can we do with local pharmacies, particularly as, you know, as we strive towards carbon neutral neighbourhoods or 15-minute neighbourhoods, whatever we're calling them. How do we make the best use of pharmacy services, particularly as they've got capacity and they are so accessible? So I just kind of throw that out, because certainly from a public health service provision, I don't think we utilise them as much as we could and should, just by definition that they are, everybody knows who their pharmacist is, people would trust and use them, and as I say, we can just think about how do our services fit better by having that open access in a more effective way, really. But first of all, I just want to, as I say, just can't emphasise, this is a painful task and a necessary task, but well done to you and Kim.
I can't take any credit for this. This is all Kim's work. So
thank you vicariously.
So I suppose just following on from your point, Kelly, going back to the previous report around primary care neighbourhoods and integrated community working, I think that is something that we need to be thinking about as we move forward those models of care, because we commented on the phenomenal success around COVID vaccinations and flu vaccinations, and a high proportion of those were delivered by our colleagues in community pharmacy, and it is the first point of access for a lot of people. So in terms of thinking through those integrated teams and ways of working, I think we absolutely can use some of the information in here, but then start thinking more operationally about how we do that locally. Richard, do you want to?
So just to endorse that, Caroline, absolutely, and I mean, I think Ian's report at the very early stage was showing the good networks between community pharmacies and general practice, and this is a really useful and worthwhile report, Naveed, whoever was responsible for producing it. I think just building on your points and Caroline's points, I think a lot of partners know that NHS England, currently responsible for commissioning pharmaceutical services, will be transferring that to integrated care boards during this year, and that might be something that this board and the borough teams will want to be discussing with the ICB about how that responsibility is fulfilled at place level, how we might want to work with public health colleagues, not only for pharmaceutical services but also the dentistry and the optometry services that come down. So maybe separately we should be having a discussion with the ICB about how to take that forward.
Any other comments, Patricia?
Just really a question, a bit following on from what Kerry said, was that I mean, I think it's really good to see that there's a good mix of independent pharmacies in the borough. But how much work was done around the viability and the sustainability of those pharmacies? So I'm really pleased to see that they're saying that they are wanting to take on additional services, but actually there is also a bit of a critical mass in a small pharmacy. And I'm not saying that I don't think they're absolutely essential, but I just wondered, given some of the things that we've said we want to do and that kind of networking, actually is a small independent pharmacy viable in the longer term unless we've got a model for paying for those services? And I just wondered how much had been done on that.
So the needs assessment didn't go into the viability of individual pharmacies. That wasn't the kind of purpose of it. But I think there is, following the kind of feedback that we had from some of those pharmacies, a desire to take on more services. And I think there's just taking on sort of Kelly's point, it's really about how we maximise that opportunity and make sure that kind of the services that we are looking to commission or procure kind of are targeted towards that.
With regards to the feedback, because you got 100% response rate, I didn't you, which is fantastic. I just wonder, in terms of starting some of those conversations about neighbourhood working, is if there is anything that's come out of those responses that it would be worth feeding into some of those neighbourhood discussions, if that, that's the next level down from the headlines here. Whether we could have a think about how we feed that in locally then to those neighbourhood discussions, because I think that gives a level of richness to then the start of some of the conversations potentially. Tony?
It will start to become evident. I have no idea what I'm talking about, but very quickly, but I'm going to let the words out. Rather than that way round, is there not something that we could or should be able to present to pharmacists in terms of like a market position statement almost? So, we are looking for, almost as if you were doing it as a procurement type sort of exercise. So looking at the kinds of services that could be ran through, and doing it that way round, because there must be an awful lot of intelligence already about where, the types of services that pharmacists are running very well, or that provide support to primary care and so on and so forth. So thinking about it almost like we're sort of commissioning from them, rather than we're just sort of hearing what they've got to say.
Yeah, I think it's probably a bit of both, isn't it? Because one of the challenges has been locally, we haven't had that commissioning site necessarily on pharmacy locally because of the way it's been structured. So we've got a bit of an opportunity to go out and have that conversation with a slightly blank sheet, but also knowing what some of the key priorities are.
Yeah, what some of the
gaps
are.
Yeah. Let's bring those two together. Lovely, thank you. Well, yes, a fantastic piece of work. So it's going out to consultation now for 6 weeks. So after that, it'll be then presumably published and feedback taken on board, and then
it's 60 days, and we will be bringing it back to board for final sign-off in September before publication in October.
Thank you. Okay, so moving on then, I think we're on to the board planner and future agenda items. So at the moment, 13th of September, which feels like a long way at the moment, but I'm sure we'll be with us before we know it. So we've got a few items. Presumably then we'll add the pharmaceutical needs assessment back on, which isn't on here at the moment. But at the moment we've got any reports coming in from policy scrutiny for the integrated performance report, and I'm sure in the meantime there'll be other elements that we add. Gary, do you want to?
Chairman, maybe bringing the 22-23 BCF plan to the September board.
Absolutely, yes, we will add that to the forward plan. Thank you, Gary. Okay, so I think that brings us to the end of part 1, so we will now move into part 2. So thank you for all of those who have been attending and watching online.